Good morning, everyone. So we're going to move on to part 2 of spinal cord injury. So we're picking back up with interprofessional care, acute care. So when you want to make sure that you move the patient in alignment as a unit, this is known as the log roll. With turning and repositioning, obviously you want to prevent injuring the patient any further. So stabilization of injured spinal segment. This eliminates damaging motion. Stabilization methods eliminate damaging motion at the injury site. It's intended to prevent secondary spinal cord damage caused by narrowing of the spinal canal or continued contusion or compression of the spinal cord at the level of the injury. So you want to carefully immobilize the patient's head and neck. The paramedics should have used a cervical collar. I had mentioned that earlier in the lecture, which is critical to maintain alignment and again prevent injury to the spinal cord during transport. Other things that you can do are decompression with traction or realignment, or craniocervical traction. So for surgical therapy, as you see, it's used following acute spinal cord injury to fix any instability in the cord. Surgeries within 24 hours associated with improved neurologic outcomes. The posterior approach, this is from the back of the spine, and the anterior approach is from the front of the spine. Fusion, this involves attaching metal screws, plates, or other devices to the bones of the spine to help keep the patient aligned. So this procedure is usually done when 2 or more vertebrae have been injured. So bone is grafted between the vertebra for more support and to strengthen the back. The bone used for the procedure can be obtained from the patient's spinal bone, harvested during surgery from another bone in the patient's body, and that's considered when you're using the own patient's body autologous, or from a donor graft, and that would be considered an allograft. So drug therapy, obviously you're concerned about preventing clots. So in order to prevent that, the patient can be on Lovenox sub-Q. Vasopressor agents, neosynephrine, or Levophed. This is used to maintain a mean arterial pressure greater than 85 to 90 to improve perfusion to the spinal cord. Other significant risks of complications, obviously you would need to watch out for arrhythmias, AFib, uncontrolled AFib, VTAC. So with the subjective data, as you read down through, health perception, health management, that's more so talking about alcohol, recreational drugs you might want to ask the patient about, or obtain information from the family. Activity, exercise, loss of strength, movement sensation, cognitive, perceptional, numbness, tingling, coping stress tolerance. Obviously, the patient is going to have intense fear, anger, perhaps denial. So with objective data, quick chilothermism, you're going to need to know this. So again, the patient is taking on the temperature of the environment. So warm, dry skin, that's neurogenic shock. So with respiratory difficulties, if the injury is at C1 to C3, you may see apnea or inability to cough. Injury at C4, Patient may have a poor cough, diaphragmatic breathing, as well as hypoventilation. So again, with hypoventilation, with ABGs, you would expect to see respiratory acidosis. Injury above or injury at C5 to T6, decreased respiratory reserve. Injury above T5, that's bradycardia and hypotension. Injuries from T5, you can expect to see decreased or absent bowel sounds, so this patient's at a greater risk for an ileus. Other objective data, urinary, so with retention for injuries between T1 and L2, a flaccid bladder. During the acute stage, you would expect some spasticity with reflex bladder emptying in the later stages, reproductive priapism, loss of sexual functioning. Neurologic, so with complete, you would expect flaccid paralysis and anesthesia below the level of injury, resulting in tetraplegia for injuries above C8, or in paraplegia for injuries below C8. Hyperactive deep tendon reflexes. Incomplete, you would expect to see a mixed loss of voluntary motor activity and sensation. Musculoskeletal, the patient would have muscle atony in a flaccid state, contractures in a spastic state. I'm not going to read through the nursing diagnoses. You can read that, as well as planning, overall goals, nursing implementation. The only thing I want to add there, obviously, so health promotion, facilitating wheelchair accessible healthcare screening exam rooms with immobilization, with the cervical collar. The squad should be using a backboard as well to prevent lateral rotation of the cervical spine. So with skeletal traction, obviously the patient is in a traction unit. Obviously that's going to release tension on those vertebrae as well as the nerves. And you see the patient who is immobilized with that halo there. So you see the SOMI brace, that's so the need for surgery that's determined after the spine is reduced. So after a cervical fusion, the patient may wear a hard cervical collar or sternal-occipital mandibular immobile brace to keep the patient in line. There's the halo vest. So after surgery, a halo vest is attached after the patient is mobile, and this allows the patient to ambulate while the cervical bones are fusing. One thing you want to think about with pen site care, cleansing with half-strength peroxide, normal saline twice a day. They need to also apply antibiotic ointment. There's also specialty beds that are often used in the management of the patient with a spinal cord injury. These will help prevent pulmonary complications such as pneumonia, and as well preventing pressure ulcers. So if you turn your PowerPoint, you'll see this Rotorest bed. I've never seen one of those before. I imagine that's pretty expensive. So stable thoracic or lumbar spine injuries, the custom thoracolumbar orthosis, also known as a TLSO or body jacket. This inhibits flexion, extension, and rotation. The Jewett brace, this is designed to give support to your thoracic and lumbar spine by preventing twisting, inflection, and bending forward. So it keeps the back in alignment. So obviously one thing that you do have to watch out for is skin breakdown. These patients need meticulous skin care. That's critical because of decreased sensation and circulation, the inability to feel irritation such as wrinkled linens or clothing. Respiratory dysfunction, complications these are the leading cause of complications that lead to death and spinal cord injury. So something to think about, if the injury is at or above C4, the phrenic nerve leading to the diaphragm may be affected and breathing can actually stop. So if the patient is exhausted from labored breathing or ABGs indicate inadequate oxygen and ventilation, this patient may need to be intubated and put on a ventilator. And as you well know, being on a ventilator puts the patient at a greater risk for pneumonia. So things that you can do for your patient, obviously with respiratory, oxygen, assist the patient with coughing, and send a spirometer, keep them in a high Fowler's position, upright. Cardiac, you want to think about DVT, dysrhythmias, because the patient is at a greater risk for bradycardia and cardiac arrest. So with cardiovascular instability, obviously you're going to think about with bradycardia, you may be giving the patient atropine. They may need a pacemaker. Blood loss, you may be giving them PAC units or red blood cells as well. You want to assess for orthostatic blood pressure as well. With the DVT, obviously you want to be looking at the calves. Is one more swollen than the other? Is there any redness? Make sure the patient has on TED hose, maybe even compression stockings, the pneumatic, the pumps as well. Fluid and electrolytes, obviously the patient may become dehydrated, so you're going to be replacing electrolytes. They may need a PEG tube for internal nutrition, or maybe a central line for parenteral nutrition. So parenteral, as you recall, it looks like a big clear bag, and it has all the vitamins, minerals, everything is broken down, and the patient receives it through the central line. With that type of nutrition, you need to be alert to, especially if the patient's a diabetic. Typically, fats and lipids are put in during overnight. So the bag now, instead of clear, it's white. So you want to think about checking that patient's blood sugar as well. Of course, other things that you want to think about, obviously the patient, if they can't eat, maybe they can't feed themselves, to make sure that you give them time. Dietary supplements, ensure magic cups, increase dietary fiber, that will lessen constipation as well. So with bladder management, after a spinal cord injury, urine is retained, and that's due to the loss of reflex control of bladder and sphincter, which results in a neurogenic bladder. patient has no sensation of fullness, which could result in a ruptured bladder. So with this initially, they typically have a urinary catheter. So with intermittent catheterization program, you can teach the patient and the family how to self-cath. This is usually done every 4 to 6 times on a daily basis to prevent bacterial overgrowth resulting from urinary stasis. So keep the urine residuals under 500 to prevent bladder distension. If the urine is cloudy, it has a foul odor, the patient maybe has a fever, you need to be aware about your signs and symptoms of a UTI. So you would want to send a urinalysis as well as a culture. Bowel management. These patients may be on stool softeners as well as a laxative. You may have to digitally check the patient. With temperature control, there can be no vasoconstriction or piloerection. Of course, obviously that's goosebumps, piloerection, so that's the erection of body hair, or heat loss through perspiration below the level of the injury. So if an infection with high fever develops, so more extensive methods for temperature control may be needed, such as a cooling blanket. Do not use excessive covers. With stress ulcers, you want to assess the patient's abdomen, look for any abdominal distension, monitor the patient's bowel sounds, check the patient's stool. You could do an occult blood to see if there's any internal bleeding. Look at your H&H. Prophylactic medications, H2 blockers, Zantac and Pepcid, proton pump inhibitors. So with proton pump inhibitors, long-term use, you have to be more concerned with those because they do change the normal flora of the intestine, and they can put the patient at risk for C. diff. So in the future, you might see more use of the H2 receptor blockers. I'm going to skip over sensory deprivation. Pain management, we talked about nociceptive pain. This can be thought of pain associated with tissue injury or damage or even potential damage. Nociceptors are sensory endings on the nerves that can be excited or sensitized and signal potential tissue damage. Medications, anti-inflammatory drugs, opioids, visceral nociceptive pain, visceral pain that refers to pain in the trunk area of the body. It includes the heart, the lungs, abdomen, and pelvic organs. So some examples of visceral pain would be appendicitis, gallstones, chronic chest pain, and neuropathic pain. I'm sure everyone's probably most familiar with this one. Typical medications given are Neurontin and Lyrica. Skincare, obviously, repositioning the patient every 1 to 2 hours. Patient's probably going to need a specialty mattress as well. Reflexes. Return of reflexes may complicate rehabilitation. Reflexes are often hyperactive, so they can produce an exaggerated response. Patient can have penile erections, spasms ranging from mild twitches to convulsive movements. Below the level of the injury may also occur. Antispasmodic drugs, a few examples of those, that would be your baclofen, Xanaflex as well. Autonomic dysreflexia, this is something that you're going to need to know. This can be life-threatening. It occurs after the period of spinal shock, and it resolves and occurs with lesions or injuries above T6 and in the cervical lesions. It's commonly caused by visceral distension from a distended bladder or impacted rectum. It's a neurological emergency and it needs to be treated immediately to prevent a stroke. So with this, you can expect to see hypertension as well as bradycardia. And of course, as you know, the CNS responds to stimulation of sensory receptors, and the parasympathetic nervous system is unable to counteract the responses. So this is the autonomic dysreflexia. It's the most common precipitating factor is, again, the distended bladder or if a patient is impacted with stool. So some manifestations, obviously you would expect the patient to have hypertension. The systolic can be 200 up to 300. The patient will complain of a sudden onset of severe throbbing headache. So if a patient complains of a pounding headache, obviously immediately you want to assess the patient's blood pressure. They can be diaphoretic, their heart rate is going to drop to 30 to 40 beats per minute. You can expect to see piloerection, flushing of the skin, perspiration. The patient's also going to complain of blurred vision or spots around the visual field. They're going to be restless. They may be very apprehensive. Nursing interventions that you want to do, put the patient in a high Fowler's, assess and remove the cause. So if the patient has a full bladder, you would want to immediately catheterize them. If a patient has a Foley in, make sure there's no kinks, irrigate the tubing, check the patient for impacted stool, remove constrictive clothing, tight shoes, undo the shoelaces, assess the environment to ensure that it's not too cool, assess your vital signs and blood pressure every 10 to 15 minutes. So moving on to rehabilitation and home care, and I'm going to skip over some slides here. So with mechanical ventilation for injury above C3, because the phrenic nerve is not stimulated and thus the diaphragm is not functional, these patients need around-the-clock care. They could have a trach. There's also what's known as a phrenic nerve stimulator or a diaphragmatic pacemaker. So these devices aren't appropriate for all ventilator-dependent patients, but they can be helpful with those who do have an intact phrenic nerve. Another thing you want to be aware of during rehab, you need to be aware of swallowing precautions, diet recommendations to prevent aspiration. With neurogenic bladder, there's some different types. You can have a flaccid, spastic, or dyssynergia. and that's a disorder of the pelvic floor muscles. So some medications for the neurogenic bladder, anticholinergics. They help to suppress bladder contraction, ditropan, detrol. Alpha-adrenergic blockers, Hytrin, doxycycline, they can relax the urethral sphincter. Antispasmodic drugs such as baclofen, they can decrease spasticity of the pelvic floor muscles. So we talked a little bit about neurogenic bowel using stool softeners, laxatives, the Valsalva maneuver with manual stimulation. This is useful in patients with lower motor neuron injuries because the Valsalva maneuver requires intact abdominal muscles. So it's used in those patients with injuries below T12. With spasticity, as I mentioned, using the antispasmodic drugs. I think we discussed skincare, pain management. Let's see. With sexuality, fertility is not usually affected. There's also a risk for precipitous delivery, and so that's defined as labor that lasts no more than 3 hours from onset of regular contractions to delivery. It's generally thought to result from abnormal low resistance of the birth canal. So you have abnormally strong uterine contractions, and there's a lack of awareness of painful contractions. Effects on the person and family. Obviously, you can expect the patient to be depressed. You know, a lot of patients, they mourn their previous life. Maybe if the patient was an athlete, maybe you need to allow your patient some time to discuss their accomplishments so they can work through the grief. And they might need some counseling as well. And I think that's it of the lecture. So if you have any questions, let me know.